Iselin.
Hello.
I'm back again to continue your assessment. I hope I'm not wearing you out too much.
No, thank you.
Okay, great. What we're going to do now is look at cardiovascular assessment. You don't look so comfortable there. Is that better?
Yes, thank you.
Okay, you're welcome. Cardiovascular assessment. So this basically has three components that we want to look at. Your great vessels in your neck, your jugular and carotids, and then the precordium, or the heart itself, and then your peripheral circulation. So we're looking at pulses and circulation to your extremities. So we're going to start with the great vessels in the neck. And actually, I'm going to seal this pillow for just a minute. Now that I got you comfortable, I'm going to get you uncomfortable. And I'll just have you, if you would, turn your head to the side away from me a little bit. What I'm looking at first is I'm assessing for any jugular venous distension, jugular vein distension. Normally, with the head of the bed at a height of about 30 to 45 degrees is how we want to assess this. And we would not expect to see any distension of the jugular veins in this semifaller's position. So what I'm looking for is any bulging veins. Her external carotid would be, external jugular would be along the side here, and internal jugular, you can just turn back this way a little bit, would be right down in here by that sternomastoid muscle where it attaches there. So I'm going to use what's called tangential lighting, which means a tangent of light shining across, as opposed to direct lighting, where I would be shining the light directly on the vein. I want to use tangential lighting because it creates a shadowing effect, and that can help me to visualize if there's any JVD going on. So I'm going to shine that light across her neck and looking for any bulging veins or undulating, rippling veins there. And I'm not seeing that at all in the area of the internal jugular or the external jugular for that matter. So no JVD noted. The next thing I'm going to do is move on to the other great vessels we want to assess here, and those are the arteries. So the carotid arteries specifically are what we're assessing. Now the carotid arteries supply the blood to the brain, so we never want to press on both of them at the same time. We don't want to deprive the brain of blood supply. It can be a problem for your patients. And so we'll assess one at a time, and I'm going to palpate right along the inside of the muscle there, and you should be able to feel a nice strong pulsation there. Typically, we rate the pulses, pulse strength or amplitude on a scale of 0, which would be absent. 1 would be a weak, thready pulse. 2 would be our expected finding, a normal, strong type pulse. And then 3, sometimes you'll see a scale of 3 or 4 even. That would be a particularly strong bounding pulse, which we wouldn't expect. So I would rate Iselin's pulses now, carotid pulses, a +2 amplitude. And it's nice and regular. Her carotid arteries are supple, they're smooth, I'm not feeling any hardening of them. I'm going to also go ahead and listen, and I would palpate bilaterally, again, one at a time, assessing her carotid arteries. I'm also going to listen to her carotid arteries for any abnormal sounds, and what I'm listening for specifically is bruits. A bruit would be a whooshing kind of pulsatile sound that would be associated with turbulent flow through that artery. So I would put my stethoscope in my ears, make sure that this time the bell side is functioning, so I'll just tap on it gently. And when I use the bell side of my stethoscope, I do not want to press hard. I just want to press very lightly so that it seals against the skin, but it doesn't press hard. So I'm just going to have Iselin turn her head this way. I'm going to find that pulse again. And I'm going to go ahead and place my stethoscope there and listen for any bruits. I'm going to also ask her to hold her breath while I assess this so that I can hear the artery and not her what's happening in her trachea. Okay, thank you. I'm not hearing any bruits, no whooshing, swooshing sounds, just a nice kind of, almost like a lub-dub kind of a pulsatile type sound, but nothing that's swooshing. So no bruits. So now we're going to move on to the heart itself, or the precordium as well. So this is the precordium, is the area over the heart. And we'll start again with inspection in this area. So I'm inspecting the chest wall, looking for any pulsations, any abnormal movements, and I'm going to say I'm not seeing any. There may be times when at the PMI, or the point of maximal impulse over the apex of the heart, you may see a slight pulsation there, which would be considered a normal finding. I'm just going to say we're not seeing any right now. After inspection, you would go to the next step of your assessment, which would be palpation. So we would just gently lay our hand over the precordium and palpate those areas near the heart or over the heart, again feeling for any pulsations or abnormal movements at the chest wall. Again, you may feel a slight pulsation down at the apex or the PMI, point of maximal impulse area. That fifth intercostal space, left midclavicular line is where typically you'll feel that if you're going to. But otherwise, I'm not feeling any pulsations. So after I've inspected and palpated, I'm going to go ahead and auscultate. We don't percuss the heart, typically. When I auscultate, I'm going to actually start with the diaphragm. I'm going to use both the diaphragm and the bell when I listen to heart sounds. I'm going to start with the diaphragm, and I'm going to identify 5 different locations where I'm going to listen. These locations are associated with the valves in the heart, and also one other area where we stop and listen because we may pick up some heart murmurs in that area. Now, what we're listening for initially is the heart sounds themselves, and they're called S1 and S2. That lub-dub sound again, S1, lub, S2, dub. So lub-dub, lub-dub, S1 and S2. You would expect to always hear those sounds. There may be some additional sounds that you hear that you'll have to tune into and evaluate more closely. You can have extra heart sounds, S3s, S4s. You can have splits of the S1, S2. You can have murmurs as well, clicks, different kinds of sounds that would be all considered typically not normal, although there are exceptions to that. For example, in a child you may hear an S3 that would be considered a normal finding. In a pregnant woman, because of the increased volume, blood volume, you may hear an S3 that would not be considered pathological. But for the most part, you're listening initially for the S1, S2, and then are there any other sounds that you hear? And if so, try and tune into what they might be. So what we're going to do is start at the first location, which would be the second intercostal space on the right sternal border. So I'm going to, again, palpate, find that sternal notch, palpate down to that rise on the sternum called the angle of Louis, and then across, only this time, unlike when I'm checking the apical pulse, I'm going to come across into the intercostal space on the second intercostal space, specifically on the right sternal border. So right along the sternum on the right. I'm going to place my diaphragm there, and I'm going to listen for the lub-dub. That's called the aortic, A for aortic location. Okay, and there, because I'm listening, or I'm hearing more prominently closure of those second set of valves, the semilunar, aortic, and pulmonic valves, that's associated with S2. And so I would expect to hear S2, the second heart sound, a little louder than S1 here, and I am. Now, I'm going to go right straight across the sternum into the second intercostal space on the left sternal border. So just across onto the left side, still using my diaphragm. This is P, pulmonic. So this sound here is more associated with closure of the pulmonic valve. And again, S2 should be a little louder. Now I'm going to continue down the left sternal border to now the third, over the rib to the third intercostal space. I'm going to place my stethoscope there. So third intercostal space, left sternal border, that's called Erb's point, E-R-B, Erb's point. And I'm going to stop and listen there. again for any abnormal heart sounds, murmurs, anything like that. I'm going to continue on down the sternum, along the left sternal border, down to the fourth or fifth intercostal space, left sternal border. That would be associated with hearing the tricuspid valve, or T. There, I would expect now to hear S1 more prominently than S2 because it's associated with closure of those AV valves. And then finally, I'm going to follow that fifth intercostal space laterally over to the midclavicular line, over to the apex area of the heart, and I'm going to listen again. And that's the M, the mitral area. And again, I would expect to hear S1 more prominently there. Now, I'm going to turn my stethoscope to now listen with the diaphragm side, and I'm going to follow the same pattern backwards. And then here, so that's M, mitral, tricuspid, Erb's point, pulmonic, aortic. All 5 locations again. All right, and I do hear S1 and S2 clearly. I don't hear any extra heart sounds, no murmurs, no S3, S4, nothing that we would comment on. So now we've looked at the heart itself, or assessed the heart itself, and we're going to move on to the peripheral circulation, or the extremities. We've already talked about the color and temperature of the extremities when we looked at, and actually edema and moisture when we looked at the integument. And so we won't comment on that again, but those are things that would be impacted by the cardiovascular status as well. We also did capillary refill when we assessed the fingernails with the integumentary system. That would be appropriate to include with the cardiovascular system assessment as well, or peripheral vascular specifically. What else? What the other things that would be relevant here would be to assess for pulses. The pulses that are commonly assessed would be radial, which is right in the groove here, kind of at the base of the thumb, inside. There's like a little groove right there, just in from the radius, and you can palpate right in that groove, and you should be able to feel that pulse. And Eislin's pulse is a +2 amplitude there. Brachial we talked about when we were assessing blood pressure as well. Up here, medial or inside to where this tendon is in the arm. Just tuck your fingers in there and you should be able to feel that brachial pulse, and again, it's a +2. Now, you also are going to be assessing the femoral pulse, which is in the groove about halfway between the hip and the groin. Right in the fold here is your femoral pulse. This will be easier to assess actually when the patient is lying flat. It'll probably be easier for you to get your fingers in the groove and really palpate that. You could try in this position, but it may be easier to incorporate that after you've done the abdominal assessment. And then we're going to move down to the legs. The popliteal pulse would be right behind the knee. You're just going to palpate again in kind of the valley behind the knee. Feel for that pulsation. Now this one is very difficult to feel. Don't be surprised if you have difficulty, and you may or may not ultimately feel this in your partner, but you need to know where you would assess for it. And then finally, the dorsalis pedis, let me give you your pillow back.
Thank you.
Or pedal pulse would be, may I just take your sock off here? Would be right on the surface of the foot here. Somewhere right in this area. Again, if you're having trouble, you may need to work with it a little bit. There it is. And find that pulse. Okay, and that should be a +2 as well. Again, when you assess peripheral circulation, you're going to assess capillary refill of the toenails as well as the fingernails. So you're assessing all the extremities, and you're going to do that bilaterally. Also, with the lower extremities, you're going to look for varicose veins, edema. We talked about with the integument, but you can also look again here with cardiovascular assessment, any swelling, edema, peripherally, any varicose veins. Changes in hair distribution may reflect a circulatory problem. And the one last thing we'll do is a brief test. It's a screening test for deep vein thrombosis or venous thromboembolus, VTE or DVT. What I'm going to do is called Hohmann's sign, and this is what's called passive dorsiflexion. Passive meaning I'm doing the dorsiflexing, Iselin's not. So I'm going to just flex her knees gently, and I'm going to pull up on her foot, dorsiflexing it, meaning pulling it toward her head like this. And I'm going to ask her if she has any pain in her calf, back of her leg, when I do that. Nope? Okay. And that's just a screening test again for VTE or DVT. The reliability of it is not that great, but if she did have pain with that, we would want to take it a step further. If she doesn't have pain, does not mean that she absolutely does not have a problem with a thrombus there. Okay, I think that's it for our cardiovascular assessment. Once again, Iselin looks as though she's doing very well. And I'll be back to continue our assessment in a little while.
Thank you.
Thank you.